Hi guys, welcome back. In this part of today's lecture on health inequality, we're going to be talking about some of the reasons, the structural reasons specifically, why we see health inequality in our country today. Okay, so to start off, I want to look at this graph together. So as you can see from the title on the right-hand side, this graph is showing us the life expectancy someone is projected to have at the age of 40, okay? And this specific graph is controlling for race, so we can take race out of the equation here. That is controlled for. So the lighter colors, right, are showing us that someone is expected to live longer, whereas the darker you get in color, the shorter, that's the word, your life expectancy is projected to be. Okay, so what do we see here? We see that people on the East Coast seem to be doing pretty well, right? Specifically, like, look here in the New England area, the life expectancy is pretty high compared to the national average, it looks like, right? And down the East Coast, really, except for these small pockets, people seem to be doing pretty well, okay? Florida's doing really well. And then what we see is that in the Midwest, life expectancies are much lower, okay? We don't really have a lot of data on this area, but we look in the Utah, like Nevada area, it's low as well. And again, we go to the West Coast and things are looking pretty high. So what does this tell us, right? One way to interpret this graph, and it would be incorrect, right, as you're gonna see, is that somehow people on the East and West Coast are just biologically more healthy, right? That somehow through the generations, people have acquired better health, or maybe don't have predispositions for certain illnesses, but that people in the Midwest maybe just have more genetic predispositions to illnesses or certain conditions, right? That's one explanation, but probably not likely, right? It's not, it would be a hard argument to make that somehow people on the East and West Coast of the country are like genetically more fit than people in the Midwest, right? And we don't really want to start making that argument. So what's happening then? It must be socially rooted, right? That there has to be some sort of social differences between these different areas of the country that are leading to these different stratified health outcomes. Okay, so for example, we could think of a few reasons off the bat, right? Maybe it has to do with access to health care. Maybe it has to do with standards for care in these states. Lack of good food or diverse food options, depending on the place that you're in. Maybe even strain from occupational stressors, right? Maybe you're in a state where hard labor is more likely to be involved in the job you have than sitting at an office desk, right? So these are some reasons already that we can just kind of think of off the bat for why we would see such different life expectancies correlated with where you live in the country, and they're not really biological, right, or genetic. Okay, so there's a lot of potential reasons, and we could speculate for a whole long time about what those all are, but I want us to look at some sociological theories that could help guide this conversation. So we're now going to look at two sociological perspectives on inequality, and for the rest of this lecture, right, structure and culture. And obviously, as the title implies here, we're going to start with structure to look at how the system of opportunities and constraints leads to different health outcomes among groups. Okay, so to start with, if you haven't already read the Lincoln Phelan article assigned for today, please go do that. It is really short; it goes by quickly, so it won't take too much of your time. Though I hope you are spending time on the course, obviously. Okay, so what we're going to talk about here is how access to different social resources leads to different health outcomes, okay? And we're going to talk exactly what we mean about social resources and why they matter. So we're going to start with the McEwen. I always mess that up. I look at it and I think I know how I'm going to pronounce it. It takes me a second always. Okay, so previously, towards like the mid-century, it was assumed that on average, the population was getting healthier, right? Because if you contrast the health of our population now to what the health of our population looked like in the 19th century or the 18th century, we're way better off, right? Life expectancies are way up. People are healthier, not suffering from as many illnesses, right? That we can treat those better. And so people started to wonder, of course, why we're healthier than we used to be. And for a long time, it was assumed this was just because of modern medicine and the fact that we have these new medical interventions that we never had before, so we could treat our population and make them healthier. Okay. So McEwen comes along, he's a social theorist, and he says, like, okay, well, like, that probably helped, right? But maybe that's not the only reason that our population is healthier than it used to be, okay? So his work in social theory and epidemiology shows us that actually these health-enhancing measures didn't have a huge impact, right? If we look at the data, if we control for that, right, and we look at the health outcomes of the population, all of these new medical inventions and interventions actually didn't do that much for the dramatic increase in the population's health. What he finds, however, is that the broad economic and social changes happening simultaneously were the main factor that made us healthier as a population, okay? So what does this mean? It means that people aren't living in slums like they used to, right? If we think about, for example, like what the Industrial Revolution looked like, people in cities were living in deep, deep poverty, right? There was not any sort of like welfare to help people out. People were starving, living in really dirty conditions where just kind of sickness was rampant, right? And so he says because of these structural changes, right, where our economy has improved, obviously we still have a lot of inequality as we've been talking about, but that inequality doesn't look quite how it looked prior to the 20th century, right, when things were people were just kind of left for dead. And these big social changes that kind of lifted the population up as a whole, people got healthier, right? That because they were better off economically and socially, they were living in these better places, they just got healthier, okay? So essentially what he is doing in his work is he's linking our social conditions to the population health, right? That if in general the social conditions of the country are good, the population health is going to be good. If our social conditions go down all of a sudden, if suddenly we have deep inequality, we're leaving people starving, right? People don't have access to health care or whatnot, the population health is going to go down. And that's true regardless of what's happening medically at that time, right? If we're making these huge medical innovations, right? Or if our doctors are kind of doing the same thing they've always done, right? So he's saying actually the social conditions that we're in matter most in terms of the population health. Okay, so what happens is the McEwen thesis is kind of really integral for thinking about epidemiology for a long time, right? He's relied upon. People think this is like, wow, such a great breakthrough. And then what happens is that people start to question, well, then why do we still see health inequality, right? If these broad social conditions are improving the health of the general population, why are some people still better off than others then, if they're still living in the same society and still living in the same social conditions as other people who are doing better, okay? And what happens is that people start to theorize, right, and this is called the fundamental causes theory, that people who have more resources have a better health advantage than people who have fewer resources. Okay, so there we go. Okay, this is like nicely visualized in this graph, which I really like. Okay, so in this graph we see life expectancy as it correlates over time. Okay, so we have these time periods listed down here, and then life expectancy, right? So obviously the higher you're going, the longer you're living. So McEwen explains, right, this general trend that over time people live longer, they're healthier, okay? The fundamental causes theory is trying to explain this gap, right? Why low socioeconomic status people are still not doing quite as well as high socioeconomic status people, right? So everyone's kind of following this upward trend, but there's still a gap between people who are better off and people who are worse off, okay? So the fundamental causes theory is trying to explain that because some people in society have access to better resources than other people, their health will ultimately be better, okay? And this makes sense if you start to think about it a little bit. So let's think for a second what resources could help sustain our health, right? Access to what resources would make a difference here. Well, maybe affording like organic fruits and vegetables, or any kind of fruit and vegetable, right? Maybe having access to leisure time to go work out, right? Do you work a job where you get off at 5 o'clock and you can go to the gym before going home and making dinner, right? Or do you work in a regular schedule? Or are you working multiple jobs where you really don't have any time off and you can't go exercise, let alone like maybe get a good night's sleep, okay? Do you work at a job where you're sitting versus a job where you're doing hard manual labor? Do you have access to money to pay for good insurance and co-pays? All of these kinds of social resources, right? And those really are social resources, impact our health, right? And we can imagine all the ways in which having those things or not having those things would impact our health in some way. So in essence, right, this theory is arguing that the people down here, right, who don't have access to as many resources are not going to be as healthy as the people up here, right, who have access to a lot of resources to help them sustain a healthy body and a healthy way of living. Okay, so I want to look at this graph now because I think it kind of hones in on this point even more. So this graph is showing us the proportion of households who find it difficult to access essential local services depending on whether or not they have a car, right? So these blue bars are the households that don't have a car, and the yellow bars are the households with a car. The bigger the bar, the more difficulty they experience accessing these different places. So generally what we see, obviously, right, is that if you have a car, it's easier to access all of these different places, the corner shop, right, supermarkets, doctors, post offices, hospitals. Obviously, if you have a car and a personal mode of transportation, you have an easy time getting to all those places, versus if you don't have a car, suddenly you need to figure out a way to get there, right, whether it's walking, taking the bus, taking a train, Ubering, et cetera, et cetera. As we see, this makes a big difference in terms of healthcare, right? That people without a car report finding it difficult to get to a doctor's office and really difficult getting to a hospital, right? So what we're seeing in this case is that a personal car is a kind of social resource that might mediate someone's access to healthcare. So in this case, if you have a car and it's easy to get to a doctor's office or a hospital, you can easily seek out healthcare to help you with an illness or to make recommendations, right, for how to take care of your body, versus someone who does not have a car might have difficulty getting there, might have to take a lot of time out of their day to get there, and might not go at all, right? If the difference between getting to a doctor's office to ask about something that you don't think is life-threatening is, you know, taking a 15-minute car ride versus maybe getting on the bus for an hour, that might be a barrier for accessing healthcare for you. But having a car, as we see here, also acts in subtler ways related to health, right? So let's consider supermarkets, for example. If you have a car, there's a lot of supermarkets available to you, right? Probably within a 20-minute driving window. If you don't have a car, you might have to resort, for example, to going to your local bodega to buy groceries, right? Or only having the ability to go to a grocery store every couple of weeks because it takes you a really long time to get there by bus, and so you can't buy lots of fresh like vegetables and fruits that will quickly go bad in your refrigerator. Okay, so again, what we're seeing here is that a car is acting as a kind of social resource that is mediating health outcomes between people who have access to a car and people who don't have access to a car. Okay, so that is the fundamental causes theory and how access and the opportunity to access different kinds of resources impacts our ultimate health outcomes. I want to shift gears a little bit now and talk about structure in relationship to our environment, right? So going into this next section, we're going to be thinking about how do our physical surroundings impact our health, right? And by that, I really do mean like the spaces we're in. How does the space we're in impact our health? And then how does that lead to population inequalities, right? So how does the health of one population in one environment compare to the health of another population in a totally different environment? Okay, so this graph is showing us asthma rates by neighborhood around Baltimore. Okay, so for this graph, the deeper the color, the higher the rates of diagnosis in that area. So what we see, and I don't expect you all to know the geography of Baltimore, but what I can tell you from what I've read, right, is that this graph shows us that asthma rates are highest in poor, predominantly Black neighborhoods near Baltimore. Okay. So then we can think about, why would neighborhood be correlated with asthma rates, right? We can think about, like, well, isn't asthma, doesn't it run in the family, or is people predisposed to asthma? And certainly that is true, right? So then we can think about, why does it correlate with neighborhood, right? Because it's not the case that all the people who are predisposed to asthma are in one neighborhood versus another, right? That doesn't make sense. We don't really see those trends. What happens is that the environment in some of these particular neighborhoods are, some of these neighborhoods, right, look very different than others in terms of their physical environment. Some of them are better for your health, and some of them are less safe for our health. So for example, what does the pollution look like in a given neighborhood? Is it near a highway, right, where there's a lot of exhaust fumes and you're kind of breathing those in all the time? Does your neighborhood have green space, right? If you think about it, if you live in Manhattan, do you live right next to Central Park where you can kind of get away from cars for a while, or do you live right in sort of the mid-city, right, where there's like a lot of traffic? Do you live in a neighborhood where there are a lot of doctors, right, where it's easy to access healthcare? Again, we can think back to that graph about how cars play a role here. Or do you live in a neighborhood where there is a local family doctor? Okay. So this is consistent, we find, across different cities. So for example, Philadelphia also has this issue, and people who study this actually often use Philadelphia as an example of how asthma correlates to your environment. Right? So some of you at this point might be asking, well, why don't you just move, right? If you live in an unhealthy neighborhood that's causing health problems, why don't you just move to a different neighborhood, okay? Many people don't have, for example, the money to move to a different neighborhood that is wealthy and has a lot of green space, right? Maybe your family's in that neighborhood and you don't want to move away from your family. Maybe your job is in that neighborhood and you don't have a car that would allow you to easily get there day to day, right? This is different from high socioeconomic status people who have that mobility, right? And think back again to our conversation about race and social class, and we had this discussion on the discussion forum too about why public schools correlate with race, right? And why we still see de facto segregation in this country. It has to do with socioeconomic status, right? And who has choice and mobility. The truth is, the more resources you have, the more wealth you have, you're able to make choices, right, to live in these neighborhoods you know are clean and safe, versus being confined to neighborhoods that are ultimately going to be detrimental to your health. Okay, so what we're starting to see here is that our environment conditions health outcomes, right? That depending on the environment we're in, our health is going to look a certain way. And that's going to differ from other areas where the environment is different, but the people have, different people have access to, right? And you might not have access to those spaces. Okay, so let's consider another example of why structure matters for our health outcomes. So for this section, I want to talk about food deserts, okay? Some of you might be familiar with this concept already, but if you're not, I'll just give you a quick review. So healthy food essentially is not accessible to everyone depending on where you live. So many inner cities, for example, don't have great access to healthy foods. This is largely because if you go into lower SES neighborhoods, there isn't a lot of options in terms of where to shop for groceries, okay, which means that you're often confined to one grocery store, which actually might not stock a lot of fruits and veggies, or you might be confined to corner stores where you can just get kind of quick, non-perishable items in many cases. So in order to get these healthy, fresh foods, you would theoretically need to travel far out of your neighborhood. And again, I want to bring us back to that graph we saw about the impact of having a car, right? And how if you don't have a car, that would be pretty infeasible for you. Or unfeasible? Infeasible? You understand my point, okay? So this is even beside the point of whether you can afford to continue to buy fresh food all the time, right? So that's not even a question yet. It's just a question of whether it's accessible to you and you even have access and the ability to buy these fresh fruits, okay? On the flip side, nice neighborhoods, right, the high SES neighborhoods have an abundance of food choice, right? There's often in high SES neighborhoods multiple grocery stores that you can choose from, okay? And so fresh food is abundantly available, in addition to the ability to grow your own vegetables in your green space in your backyard and community gardens, et cetera, et cetera. So we could consider the stereotype, for example, that a neighborhood is gentrifying when a Whole Foods pops up or a Trader Joe's, right? And this is related to food deserts, right? The fact that all of these grocery store choices are correlated with the wealth of a given neighborhood, because these grocery stores know that those people have money to spend on lots and lots of food. Okay, so what happens then is that people in low SES neighborhoods have to resort to eating less healthy food, right? Because the fresh food just is simply not available to them. So this means that people are getting, on average, fewer nutrients, right? Which leads to higher rates of child obesity, heart disease, et cetera, et cetera. So we see now it's not just a problem of what people choose to eat, right? And that is largely where the conversation around health and obesity and heart problems relies, right? We talk a lot about people's choice and eating unhealthy, and we're often not talking about what opportunities people actually have to eat healthy. And if we start to look at food deserts, what we see is that many people in this country don't actually have the opportunity to be eating healthy foods that they really want access to. Okay, so this is to sort of wrap up this conversation of why structure matters for health inequality, right? We see from talking about the fundamental causes theory and food deserts and all of this, right, and neighborhood environmental causes, that our health is often out of our control and is just a property of what resources we've obtained throughout our life and what conditions we live in, right? What neighborhoods we live in. Do we live in a place that has access to food or not? And so that's really what we mean when we talk about structural causes of health. We're talking about what opportunities, what constraints we're experiencing that lead to these different health outcomes over the course of our lives. Okay, so that is going to wrap it up for section 2. In part 3, we're going to move on and talk more about why culture matters for health, why these values and norms that we have matter in the long run for our health outcomes.